Actually, when we talk about lesions of the visual pathway, we have to first understand the basic anatomy of how what is the visual pathway, and secondly, how these lesions can be quantified or they can be measured. So, like we all know, the sensory part of the eye, the sense organs, the eye is a sense organ, but the part of the eye which actually is the sensory part is the retina. The fibers from the retina, they combine to form the optic nerve. The optic nerve consists of ganglion cells, which are second order neurons. They continue to in the optic nerve till the optic chiasm. In the optic chiasm, the nerves of both the pathways, they merge. A little bit changing or mixing up, it occurs. And after that, what they become is called the optic tract. After the optic tract, the fibers, they end. Those secondary order neurons, they end in the lateral geniculate nucleus. And from the lateral geniculate nucleus, the third order neurons, they arise. Those third order neurons, they make up the optic radiations. And these optic radiations, they end up in the occipital cortex, the ocular cortex, or the visual cortex. After second year physiology, you must have read that there's a primary cortex, then there's a secondary cortex. Primary cortex has some basic functions, contrast, sensitivity, difference between recognizing shapes and patterns, etc. And the primary and the secondary and the tertiary cortices, they make sense of what we're saying, and they correlate with information with our memory banks and all that stuff. It happens. So that was a little bit about the anatomy. Yeah, it's pretty straightforward. But the thing is, that was pretty straightforward. But the thing is that what the retina sees is not straightforward. If you look closely at this picture, at this figure, you can see that the blue part in the right eye, it indicates the nasal part of the retina. It does indicate the nasal part of the retina, and this nasal part of the retina receives light impulses from the temporal visual field, or the right side or the lateral side of the visual field, or the external world which we're perceiving. So the lateral part of the external world is being perceived by the medial sensory receptors, right? Temporal part is being perceived by the nasal receptors. Similarly, on the other side, it's the same on the other side. The retina, the retinal receptors on the nasal side, they are receiving light impulses or stimulation from the temporal visual field, the temporal side of the external world. ये थोड़ा सा एक उल्टा सा relation बन गया है, and this is somewhat confusing if you don't understand this, because this relation is मतलब इसमें further complication ये आ जाती है कि the fibers, they cross at the optic chiasm and they go to one side. You can see the blue fibers, they go to one side. What this means is that one side of the external field, meaning the temporal field, has usko perceive करने वाले fibers, the fibers which are perceiving the temporal field externally, they are present at one side. Okay, the temporal field of one side is present at one side. So ये थोड़ा सा एक confusion से आ जाती है. If we understand the relation between these fibers, how they perceive the external visual fields, and how they decussate, crossover, and maintain their relationships throughout, we'll be able to understand with ease the visual pathways and the lesions on how they are affected. So I think the best way to go about is to show you guys some visual field abnormalities, discuss clinical cases or the scenarios in which they occur. And after that, we'll come again and have a brief discussion over this. So A, B, C, D, E, F, G, and H, I, K, they all mark different places where which lesions can occur, where which any abnormality, any disruption can occur. Okay. So have a look at it, we'll discuss it again. How do we know that there is an abnormality in this pathway? Okay. If there's a retinal lesion, as in A, because A is clearly at the part of the retina, we know that we can see, we can examine the patient and we'll see something on the fundoscopy. You can see the many types of retinal pathologies. We can see some optic disc pathologies as well. Okay, and there might be other changes. Will tell us, all right, the lesion which is occurring is at A. But with a simple ocular examination, sometimes we're not able to directly tell whether the lesion is at the optic nerve, at the optic chiasm, at the radiation, etc. So the thing is, how can we tell where these lesions are?
Perimetry.
Perimetry, right? So perimetry, there are some things or clues which help us know. Perimetry is a very important investigation because it helps us tell where these lesions are. And if we know the characteristic pattern of visual field losses in different diseases, we will be able to identify the location of the lesions. I think perimetry is the main thing which we need to know at our level क्योंकि उसी के इर्द-गिर्द सारे cases revolve करते हैं. There are some other clues as well. We'll discuss them if they arise. So let's move on and let's discuss our first case for the day. So what is important in our first case? Let's see. The first important thing, like always, is the age of the patient. It tells us a lot about symptoms and it's a very important thing to know. So she's a 35-year-old female. She presents to us with disturbed vision, which has been somewhat worsening over the past year. So there's a gradual disturbance in vision. Okay, it tells us there's something gradual. Now, difficulty noticing things are present to her sides and regularly bumps into tables and kitchen tops. Now, this is very peculiar. If a person, अगर आपको ना पता हो कि आपके इर्द-गिर्द क्या है, तो you're always bound to walk into objects, strike objects, चीजों में जाके लगेंगे. This is what she's happening. She has difficulty noticing things which are present to her sides and regularly bumps into tables and kitchen tops. Okay? Her past history involves visit to the hospital for amenorrhea. A Humphreys visual field is performed. Visual field is given over here. Where is the lesion located? Acha.
Chiasm, optic chiasm.
Optic chiasm, right? So first thing, yes, optic chiasm. So the first thing is that let's see the visual field. This is a Humphreys visual field. It's a type of perimetry. और मतलब मैं आपको यही दिखा रहा हूँ because I find it very easy to understand. So in this Humphreys visual field, we should have had a blind spot over here in both the eyes, right? Because this is the temporal side of both the eyes and the inside is the nasal. So what do we see in the visual field in this Humphreys visual field on perimetry? We see that both nasal fields are relatively all right, but of both the eyes, the temporal fields have been affected. Okay? Both the temporal, yes, superior temporal, inferior temporal, superior temporal, inferior temporal. There is bitemporal loss. And that loss is in half the field. You can see that how it's characteristically in the half. It's remaining to the lateral side. The nasal side पर R है, but the relationship is quite good. उसको respect कर, it's not coming inside, it's not haphazard, it's not wavy. Okay? If it would have been wavy, it would have been something like this. It's not that. So there is bitemporal because it's occurring on both sides, and it's a hemianopia because one half of the visual field is being lost. This is bitemporal hemianopia. And bitemporal hemianopia, as you said correctly, it is a sign that the optic chiasm is being affected. Now, can you tell me why? What is affecting the optic chiasm? Based on this history alone, can you speculate? Can you make an assumption of what is causing this problem?
Pituitary gland.
Which type of pituitary gland tumor? Which type of pituitary gland tumor, right? Of course, it's an endocrine tumor because pituitary tumors, they are endocrine. There are 5 types of cells in the pituitary gland, 3 in the anterior, 2 in the posterior.
Gonadotrophic?
Can you repeat that? मुझे आपकी आवाज नहीं समझ आई. कट गई थी. prolactinoma, right? So this patient is most likely suffering from a prolactinoma. If you read in pathology, prolactinomas are one of the commonest pituitary adenomas. Okay. So how can we tell that there is something? The first thing is that we locate the anatomy, correlate the anatomy with what we found on the visual field. Visual field tells us that it's bitemporal hemianopia. That is the first thing. So we know that, all right, the optic chiasm is being involved. Chiasm pe gadbad hai. Second thing is that this patient is relatively young, 35-year-old. You know that menopause, it does not occur in such an age. It usually typically occurs after the age of 40. 40 is still early, but it usually occurs around 45, 50. That is the age of menopause. So this patient has early menopause, or if it's not early menopause, she has amenorrhea. So, but she should have other investigations done. But this is a correlation that tells us, all right, that there's a pituitary mass, and the mass is most likely amenorrhea. Mass is low likely a prolactinoma because prolactin causes amenorrhea. So this is इसी तरह ही आपको prof में case आएगा. A prolactinoma or a pituitary adenoma, it will lead to a bitemporal hemianopia. और यही से आपको जो है ना scenario most likely इसी तरह ही आता है. Another situation or another condition with which pituitary adenoma can present, किस तरह present कर सकता है? How do you think a pituitary adenoma can present otherwise? In relation to in relation to ophthalmology, right? एक तो presentation होगी कि the patient presents with bitemporal hemianopia. There can be another galacturia. बिल्कुल. I'm not talking about the endocrine effects. I'm talking about the ophthalmological effects. Ophthalmology में आपको कैसे presentation मिल सकती है pituitary adenoma की? It's a disease we studied a few days back. हम पिछले 2 दिन से एक ही topic पढ़ रहे हैं. उसके अंदर एक और situation थी जिसमें हमने पढ़ा था. Neuropathy, optic neuropathy. It can present with optic neuropathy. ठीक है, compression ज़्यादा हो तो optic atrophy हो सकती है. You're right. You have good concepts. But in 4th year, they are unlikely
Compressive
to
optic
ask you.
neuritis.
बिल्कुल हो सकता है. बिल्कुल हो सकता है. If the compression is large, but if you मतलब आप दोनों को देखें तो both of these what you said, they both involve the compressive effects, and bitemporal hemianopia is itself a compressive effect. Prolactinoma can also present with papilledema. Okay, the papilledema was the answer I was looking for. So because prolactinoma is an intracranial tumor, एक तो इसका direct pressure effect होता है chiasm पे, that is why bitemporal hemianopia is occurring. If it does not press on the optic chiasm, but if it is large enough to cause a pressure effect, then the patient can present with bilateral papilledema and other symptoms of raised ICP, including nausea, vomiting, a diffuse headache, etc. तो ये एक ऐसा है कि मतलब ये एक ही चीज है जो 2 clinical scenarios cause कर सकती है. Pituitary adenoma आपको मतलब context clues मिल जाएंगे clinical vignette में, case में या SEQ में, and then either they will tell you about a papilledema, उसके signs and symptoms दे देंगे, or either they will point you towards bitemporal hemianopia. We discussed वैसे हमने discuss किया था इसके सिलसिले में, but we discussed raised ICP, and the treatment is the same, that we have to remove the tumor, we have to manage the symptoms, etc. Surgery perform करेंगे, that is the definitive treatment. So this was a case of bitemporal hemianopia due to a prolactinoma or a prolactin secreting pituitary adenoma. Let's move on to our second case. In 4th year, they will not ask you about any of the symptoms or any of the signs or any of the correlations. Okay? They just want to know how good your interpretation of visual fields is and how can you मतलब कि आप कैसे locate कर सकते हैं कि अच्छा visual field में ये मसला है तो lesion यहाँ पर होगी. They won't ask you to make a good, very broad diagnosis. So whenever you're presented with a case of visual field abnormalities, first look at where the lesion is and then correlate के कहाँ मसला हो सकता है. So let's see. Our patient is a 56-year-old asymptomatic male presented to our hospital for a routine ophthalmic examination, congenital right hemiparesis. This has a correlation, but it's not important for us to know. And no other relevant medical history. A perimetry was performed. Where is the lesion located? That is the simple question. So
Have
look,
optic tract.
पहले देख तो लेना एक बार. आप लोगों ने देख लिया, मैंने क्या फोकस करके दिखा दूं. I want to focus on the visual fields and how we can थोड़ा सा उस पर भी discussion कर लें because it helps us a lot. This is the right eye. This is the blind spot. This is the left eye. थोड़ा सा उल्टा दिया हुआ मैंने. If you look closely तो आपको समझ आ जाएगी. So what is happening in this perimetry, in this Humphreys visual field? In the right eye,
left-sided visual loss.
Okay, in the right eye, there is a nasal hemifield loss. Hemi ka matlab half. There's a loss in the right eye, and there's a half temporal loss in the left eye. Meaning that in both the eyes, the loss of visual field is on the left side, and a half of the retina is being around. So it's a left hemianopia. Okay, it's a left hemianopia because the left side is being around, and it's a homonymous hemianopia because the lesions are on the same side, on the same sides of the visual field. The left homonymous hemianopia. This is a left homonymous hemianopia, and this is most likely due to optic tract lesions. Congenital right hemiparesis, all right. So, कौन side, किस तरफ को optic tract है ये? This is an optic tract lesion, you're right. Which side optic tract is this?
Right side.
So the right-sided optic tract, because if we relate the anatomy, we will know कि जो left side है, this is the left side. The nasal fibers, which are actually seeing this part of the field, they go towards the right side. Similarly, this is the right temporal. This is the right nasal. The right side के जो temporal fibers हैं वो तो उसी तरफ रहते हैं. So this is a right-sided optic tract lesion leading to a left homonymous hemianopia. Yeah, this was relatively simple. Yeah, you study these things in second year physiology, and it's not much. The next case is somewhat tricky. Scenarios मैंने उठाए हैं different clinical cases से. So because they're clinical cases, so they have a lot of investigation, examinations, clues, और वो सारा कुछ उनमें है. What is important for us is the perimetry, and we have to identify where the lesion is located. Okay. So perimetry was done in this patient. And on perimetry, this is what we are saying. This is the right eye. This is the right blind spot. This is the left eye. This is the left blind spot. So what are we saying?
Right homonomous hemianopia with superior quadrantopia.
Achha, so the first thing is that we have visual field losses in only one quadrant. So it's not a hemianopia because hemianopia means that there's a loss of visual field in there's a loss in half of the visual field. Okay, this is a hemianopia, half of the visual field is lost. This is a hemianopia, half of the visual field is lost. We're only losing a quadrant, so it's a quadrantinopia. Okay, this is a quadrantinopia. Yes, you're right. Which quadrantinopia is this?
Superior quadrant.
बिल्कुल ठीक है. It's a superior quadrantinopia because a superior quadrant is being involved. So which superior quadrant? अगर ये left homonymous hemianopia था, so is this a right superior quadrantinopia or a left superior quadrantinopia?
Right superior.
Right superior quadrantinopia, right? Because if the person is seeing forward, this is the right eye, this is the left eye. His right side, the right side of his visual field, the right superior part of his visual field is being affected. This is the right superior quadrantinopia. but where is the lesion located? That is the big question. Okay, this was an yes,
Nitrogeniculate.
yes, you're
Left
right.
optic tract.
Okay, so we have a few different answers now. This was an MCQ this year in our prof. उसमें हमसे उन्होंने पूछा था कि there is a superior quadrantinopia. Where is the lesion located? So the lesion is located in the optic radiations. That is the first thing. Left optic radiation inferior fibers. ठीक है? What are these inferior fibers called? That's the big question. मतलब how do you remember these fibers? इनको आसान करने का एक तरीका है. There are inferior fibers. You're right. Where are they present? And based on the present, these optic radiations, they have a name. Temporal lobe lesion. Now this is the answer. If you don't understand this, don't worry. इसको हम अभी explain करते हैं after we've done this. So the lesion is most likely in the temporal lobe. If quadrantinopias की बात करते हैं, तो they will ask you whether the lesion is in the parietal lobe, or whether the lesion is the temporal lobe, or whether it's in the right side, or whether it's in the left side. So this patient has a temporal lobe lesion on which side? With right homonymous hemianopia. किस तरफ होगी?
Left.
Left side. So he has a left temporal lobe lesion. इसको हम अभी डिस्कस करते हैं, ठीक है? Once we go back to that initial figure, थोड़ा anatomy के साथ थोड़ा चलते हैं. This was a quadrantinopia, which can be superior or inferior, left or right. You have to remember that quadrantinopias, they occur due to lesions in the optic radiations. That is the important thing for us to remember at this part. And the last case for today, छोटा topic है. Again, let's see where the location is. What the location is of the lesion. And the rest of the history, थोड़ी सी correlation हम कर लेते हैं. But the important thing is that we have to see the visual field. We have to locate the lesion based on the anatomy. Let's look at the visual field. This is the right eye. This is the left eye. This is the blind spot of the left side. Again, blind spot of the right side. क्योंकि पहली blind spot है उसके एरिया स्कोटोमा आ गया इतना बड़ा. There's a visual field also. We can't appreciate it that much. What are we seeing? What is the lesion here? ठीक है. So on the first side, it's there's half of a visual lesion. There's a hemianopia. There's a hemianopia because half of the visual field is being affected. Which half? Temporal of the right side, the nasal of the left eye. So it's a right homonymous hemianopia. Okay, because right side of the visual field is there. But we can see that the central part of the field is somewhat spared. Okay, it's being spared. Okay, compare it with the fields over here, okay, and the fields over here. You can see that there is a sparing of the central part, and as we know, central part is supplied by the is perceived, or the stimulation is of the macula. So this is macular sparing. So this is a right homonymous hemianopia. You're right, with macular sparing. Yes, you're also right. Macular sparing. So this is right homonymous hemianopia with macular sparing, and the lesion is located where?
Left.
Left side. Okay, the left occipital lobe. So these are the commonest lesions which we will expect, which we will encounter in our prof examinations and even in our vivas. थोड़ा सा इसको मुश्किल बनाते हैं.
पार्ट जो स्पेयर है इसकी क्या वजह है?
इसकी क्या वजह है?
ये जो पार्ट थोड़ा सा स्पेयर हो गया है,
पार्ट स्पेयर हो गया,
ऑक्सीपिटल रीजन का, उसके साथ क्या रिलेशन?
ठीक है, मैं आपको बताता हूँ. I will tell you. तो चलो हम इसी से स्टार्ट करते हैं. So this is the optic radiations and this is the occipital cortex. Occipital cortex lesions में macular sparing हो जाती है. उसका मतलब नहीं है कि हर किसी में होगी, लेकिन उसमें हो जाती है. What is the reason? जब हम बात करते हैं इन फाइबर्स की, तो in the primary cortex, which is around this fissure, calcareous fissure के इर्द गिर्द होता है. So some fibers, they are present anteriorly, they end up anteriorly, and some fibers they end up posteriorly. इसमें the reason is sparing की reason ये है कि macular fibers they end up at the posterior part or the posteriormost part of the occipital cortex, whereas the other fibers which supply the fields, the temporal, the nasal fields of one side, they are present more anteriorly. So whenever there is a stroke or whenever there is a lesion which presents or starts to affect from the anterior part, the posterior part is spared in the start. That is why these lesions, they have a homonomous hemianopia with macular sparing, because the radiations, the third order neurons which are ending in the occipital cortex, they are present at the posterior most part. जो occipital cortex का part macula को cater कर रहा है, that is present posteriorly. तो इसको थोड़ा सा explain मैं करता हूँ दोबारा से. तो eye के अंदर, if there's an eyeball, there's a retina. So you know that if a person he has a half loss of visual field in only one eye, आपको खुद समझ आ जाएगी कि that lesion is only in one eye. Similarly, if there is complete blindness of one eye, ठीक है, दूसरे के विजन ठीक है, तो आपकी खुद सेंस बता रही है कि all right, nothing is happening at chiasm, things are happening or the lesion is present in front of the optic chiasm. Okay? This is plain sense. So anatomically, when we see these visual fields or हमें एक abnormality locate होती है, we will also find different things which support our location. और कहने का मतलब, if I put this in another way, the lesion, location of the lesion will have other symptoms and other signs as well. For example, if a patient who has an optic nerve disease, उसमें अगर एक nerve, एक आंख का मसला आ रहा है, if the right visual field is being affected, then उस patient में हो सकता है कि relative afferent pupillary defect भी हो. उस patient में आपको और signs भी मिल सकते हैं. उस eye के अंदर आप CT MRI कराएं, you will find things. Similarly, if there is something occurring at the chiasm and we have a wide temporal hemianopia, so we can have papilledema as well. We can have cranial nerve palsies as well, third, fourth, and fifth, and sixth cranial nerve palsies. Okay. Similarly, when we move back to the optic tract, again, we can have different types of abnormalities over here. तो थोड़ा सा anatomy के साथ इसका correlation आता है. So the optic chiasm, as you know, is present just above the sella tertica. Sella tertica के साथ नीचे pituitary है, उससे आगे क्या कहते हैं sinus है, वहाँ पे third, fourth, fifth, sixth nerves पड़ी होती हैं. That's a little bit out in anatomy. So whenever you expect that the sella tertica is being affected, you will also find similar effects or relations. All right, this is also happening. Coming back to the optic tract, we can see that the optic tract on the left side over here is receiving the right visual field. Right side की visual field आ रही है ना, it's being perceived by the blue fibers and they are ending up on the left side. So in addition to a visual field problem, do you think that this patient will have any other problem as well? चलो इस सवाल को मैं थोड़ा सा differently करूँ. Pupillary reflex, right? It's because we know that on some of the fibers they end up in the lateral geniculate body, और वो फिर आगे जाके occipital cortex जाते हैं, whereas some other fibers they do not end up in the lateral geniculate body. They go down into the pretectal region. Superior inferior colliculus का आपने पढ़ा होगा, superior colliculus से pretectal region में जाते हैं. From the pretectal region they go into the Edinger-Westphal nucleus of the third nerve, फिर वहाँ से fibers जाते हैं towards the eye. So it's a pupillary reflex pathway जो आपको याद भी करना है, और कुछ fibers वहाँ चले जाते हैं. So if those fibers are affected, what do you think will happen? That is a big question. Okay. In the left optic tract, if these fibers are being affected and some of these fibers, बोलें.
I repeat the question.
Afferent pupillary defect.
Afferent pupillary defect, ठीक है. अच्छा मुझे आवाज कट रही है. आई एम नॉट श्योर कि मेरे इंटरनेट का इशू है या क्या है, तो प्लीज आस्क. तो डायरेक्ट रिफ्लेक्स कौन, ठीक है, दैट इज अ गुड कॉन्सेप्ट, आपको पता है। अच्छा, रिलेटिव एफरेंट प्यूपिलरी डिफेक्ट का मतलब है कि देयर इज अ स्लोइंग डाउन ऑफ द प्यूपिलरी रिफ्लेक्स, और मतलब थोड़ा सा कंडक्शन में स्लो है, दैट इज व्हाई इट्स कॉल्ड अ रिलेटिव, बिकॉज इट्स रिलेटिव टू वन आई। अगर बिल्कुल ही नहीं आता तो इट्स कॉल्ड एन एब्सोल्यूट प्यूपिलरी डिफेक्ट, ठीक है, और एफरेंट प्यूपिलरी डिफेक्ट आर खत्म हो जाता है, सिर्फ एपीडी रह जाता है। So that happens when we have a problem with one eye. If you can see the optic tract में we are actually having fibers from the left temporal retina and the right nasal retina, which are both seeing the right field, right visual field. So if the optic tract is affected, okay, we will have a pupillary defect. But what kind of pupillary defect will we have? That is the question. Okay, it's all in this anatomy. If you look closely at this anatomy, everything is here. If the blue fibers, which are in the left optic tract, they are being affected, what will happen? The pupillary reflex.
Direct pupillary reflex would be affected of the affected eye और consensual हो जाएगा दूसरी eye का।
ठीक है, कंसेंशुअल भी हो सकता है, ठीक है, राइट, डायरेक्ट इफेक्ट होगा, कंसेंशुअल भी इफेक्ट हो जाएगा, तो यू आर राइट इन सेंस। चलो, आई विल आंसर दिस क्वेश्चन, ठीक है। लुक एट द ब्लू लाइंस, ठीक है, दे आर रिसीविंग इम्पल्सेस फ्रॉम द राइट साइड, ठीक है, both in the right side. And if we say that this tract, optic tract is being affected, so yes, you're right, थोड़ा सा temporal effect पड़ेगा। क्या होगा कि if we talk about the right eye, the blue fibers of the right eye, if a person is shown a light from this side, ठीक है, what this mean कि अगर हम एक concentrated beam of light, if we shine a concentrated beam of light which falls on this side of the retina, we will not have a pupillary reflex, क्योंकि ये fibers इधर जा रहे थे optic tract में and they are being affected. But if we shine a bright light, simple bright light from this side, and it falls on this part of the retina, and we will have both a direct reflex and both a consensual reflex in the other eye. Similarly, if we shine a light from the right side into the left eye, we won't have a pupillary reflex because these fibers are being affected in the optic tract. But if we shine a light from this side, okay, these fibers are not affected. We will have both a direct reflex and a consensual reflex. तो हो क्या रहा है? We are having a hemianopic loss of pupillary reflex. Half of the visual field is unable to elicit, unable to respond with a pupillary reflex. और ये मसला जो होता है, this loss of pupillary reflex in half the visual field is very characteristic of optic tract, क्योंकि optic tract के बाद तो fibers वैसे ही लैदा हो जाते हैं। इसका मतलब ये है कि अगर optic radiations affect हो रही हैं, we will not have any issue with the pupillary reflex. ठीक है, आपको ये बात समझ आ गई है? I hope I've been clear enough. You've understand this thing. Because the fibers which are the pupillomotor fibers, the fibers of pupillary reflex, वो geniculate body से पहले ही गायब हो जाते हैं. So optic radiations or effect of the optic radiation, they will any region of the optic radiations, it will not cause a disturbance in the pupillary reflex. This is how we can correlate. मैं repeat कर देता हूँ फारिया, ठीक है। The fibers आई के अंदर जो fibers होते हैं, they are sensory. हम बात करें sensory because they जो light impulses आ रहे हैं cortex तक पहुंचा रहे हैं. Some other fibers they are pupillomotor, meaning that they relay impulses to the Edinger-Westphal nucleus to the pretectal region, and they form a part of the pupillary reflex. Pupillary reflex में वो involve होते हैं. So if we have a lesion of the optic tract, अच्छा ऑप्टिक नर्व की लीजन है तो वो तो आपको पता है कि उस तरह से कंप्लीटली लूज हो जाएगा। अगर पूरी चलो ऑप्टिक नर्व हम एक तरफ की काट देते हैं we know that we will have a complete loss of reflex on that side. और इस तरफ right turn करेंगे तो concentric reflex भी नहीं हो पाएगा because the optic nerve has been transected completely. But if we cut the optic tract, let's say on this side, what will happen? The fibers which are passing through this optic tract, the red fibers, they will not be able to perceive light and have a pupillary reflex. तो pupillary reflex लेकिन हमने देखा कि ये fibers सिर्फ half fields की ला रहे हैं. On the right side, they are receiving fibers from the right temporal field and from the left nasal field, meaning pupillary reflex is being lost in half of the visual field. This is different from optic nerve lesion, जिसमें complete loss हो रहा था पूरी visual